Welcome to week 5 of the evaluation and treatment of auditory processing disorders. This is Suzanne Foley, and this week we're going to be talking about comorbid conditions that can occur along with auditory processing disorders. Some of those conditions include language disorders, reading problems, attention deficit, multiple sclerosis, dyslexia, and autism. There are some statistics that are well known regarding comorbid conditions with auditory processing and attention deficit. One of the challenges is that depending on the criteria used to diagnose auditory processing, you're talking about a small percentage of students. And so making those correlations with other groups can be a challenge. For example, the statistics in regards to attention deficit and language disorders has a very wide range because it depends on the criteria used for the diagnosis. There are 3 different types of auditory processing deficits, and we've talked about these in terms of causes, that the majority of them have an underdeveloped corpus callosum or a delay in the auditory development. And then we have a very small percentage that have an actual damaged system. And so depending on what the cause is, it also may affect what comorbid conditions are present. The most commonly misdiagnosed condition or confused condition with auditory processing is attention deficit. And that's primarily because the behaviors that you see in both diagnoses are very similar. They have decreased ability to understand and background noise. They have poor listening skills. They have underachievement in their academics. And so certainly as you look at the students and watch their behaviors, they're very similar if there's attention deficit versus auditory processing. So if you look at some of the statistics of 3 to 5% of the school-age population has auditory processing, and then you see that 10 to 20% of the school-age population are estimated to have attention deficit. So there's more children that are going to have attention deficit than there are auditory processing. And I find the same correlations in my clinical work, that there are more children that I refer for further evaluation and treatment of auditory or of attention deficit, and I'm ruling out auditory processing. We've talked a little bit about peripheral hearing in terms of when you're diagnosing auditory processing, you are assuming it's normal peripheral hearing. They can hear the beeps. There can certainly be underlying auditory processing deficits in students with peripheral hearing loss, but we're very limited in the tests that we can use to evaluate them, and it cannot be any more than a moderate hearing loss. Some of the tests that we can use for the with the presence of peripheral hearing loss is dichotic digits and duration pattern test and the SSW. So we really are looking at, in light of a symmetrical hearing loss in both ears, is there an intraoral difference in dichotic digits? Is the right or the left ear showing worse or better than the other? Which we would expect if there's a peripheral loss, it would be even. So if there is a difference between the left and the right ear, then we might suspect that there's some underlying processing problems. And then we talk about language delay or language processing. There is a difference between auditory processing and language processing, and it can be very commonly confused. Auditory processing is a clarity issue. So from the time the information hits the ears till it gets to the top of the brain, is the child hearing cat for cat? When you get to language processing, you're talking about a top-down phenomenon. Yes, they may hear cat for cat, but did they know it's an animal? Can they compare it to another animal and talk about the similarities or differences? Can they label it, give characteristics of it, describe it, read it, write it? And so there are differences where auditory processing is the input to that, and language is the meaning or the content of what they hear. Now, I've said earlier that if you have an auditory processing problem that leads to clarity issues, meaning they hear catch instead of cat, are they going to have trouble learning what a cat is? And absolutely, because they think you're talking about baseball and you're talking about an animal. So it can lend itself to learning and language difficulties because the student is unsure and not on board with what you're saying from a clarity perspective. But language has to do with the meaning of what they hear. One of the challenges with that is the most common or well-known description or definition of auditory processing by Jack Katz is what the brain does with what it hears. And that is certainly true, but it is a little misleading because it assumes that the brain understands the meaning, and it doesn't. It's just what information comes in and the clarity of it. There's a lot of controversy on otitis media and the relationship between otitis media and language development and auditory processing skills. And the challenge is that our diagnostic criteria for otitis media is dependent on a lot of things. Number one, it's dependent on parent report. So in your case history, when you ask, has your child had a history of ear infections? Not because parents are being misleading, but just because of their perspective. My experience is if it's the first child, they may say, oh yes, we had lots and lots of ear infections. We were at the doctor's all the time, and they maybe had 2. Where if it's the 5th child and you ask, the parent will say we didn't have any, and the child had 2 sets of tubes. Again, not because they're being dishonest, it's their perception. And so that's why it's important to get medical records from the physician's office. The other issue that has come up in the last 5 to 10 years is that doctors are not actively treating otitis media. So I do a lot of hearing tests in our early intervention program, the 0 to 3 program, on 2-year-olds that are getting ready to enter speech and language therapy due to a delay. And I can see a red ear, abnormal tympanograms, abnormal hearing test. I can send that child to the doctor that afternoon, and the doctor will say, come back in 4 to 6 weeks. If the child is not symptomatic, meaning they don't have a fever or are in pain, typically the doctors are not going to treat it, and they're going to let it run its course. So there may be children out there that have ear infections that have not been diagnosed despite parents trying to get treatment. That also does not account for all of the children that we see that have uninfected middle ear fluid that may or may not be causing some alteration in the clarity of the bottom-up signal. And I say the description I give is that they might be underwater a little bit from that congestion. And those students cannot describe to us what's going on, nor do we have any symptoms. And any of you that work with children also know that we're just seeing a huge amount of children that are congested all the time. And so that certainly can cause issues, not only in terms of what they're hearing, but how they're focused during the class. So if you look at the literature about does otitis media, is there an incidence of that with a language delay or auditory processing? The literature is 50%. Yes, there is a correlation versus no, there's not. And I think it's difficult to really say because we don't have a good number of children that are actually diagnosed or would be considered otitis media. And until we get that clear, it's going to be difficult to quantify it. The other issue is what does constitute chronic otitis media? I have some children I see that have had 1 infection, but it lasted a year back to back versus 5 concurrent. So there's not a clear definition either of what chronic means. And that can be an issue when you're looking at, is there a relationship? I want to spend a little time on the differences between auditory processing and attention deficit because it does impact our ability to evaluate and treat these conditions. I am always surprised that there are many professionals and parents that don't realize that there are different types of attention deficit. So when we talk about auditory processing, I've listed our 5 skills there. that we want to evaluate. And then we look over at attention deficit. There is the typical ADHD hyperactive 7-year-old boy that drives everybody nuts that we all know about. But there are a percentage of students that have inattentive ADD where they are sitting there looking at the teacher, attending, looking like they're attending, but information is coming in and it's bouncing right back out. They have no retention of the information. And those are much harder to diagnose, and they also look very similar to auditory processing. Also, if you have a family, a parent that comes in and you have a student with inattentive ADD, often I'll hear, well, my older son has ADHD and this child doesn't look anything like them from a behavior standpoint. And that's because there are different types of attention deficit. And there, in particular, girls have inattentive ADD, meaning they're not behavior problems, they're not fidgety, they're not bouncing off the walls, but they are not either retaining information that they hear. And certainly you can have a combination. The controversy about the differences between the two diagnoses is such that they've actually done studies where they gave stimulant medication to students with auditory processing. And one of the studies, two of the studies concluded that yes, the students' focus improved because they were given a stimulant medication, but their performance on tests of auditory processing did not improve, which makes sense because the actual mechanism for deficits in auditory processing has to do with the myelin and the neuron firing, the developmental delay in those connections, where attention deficit has to do with the neurotransmitter chemical makeup in the frontal lobe. So you're talking about two different areas of the brain and two different mechanisms. So it has been well documented that they are two separate disorders. The challenge is behaviors look the same and some treatments are appropriate for both. So for an example, preferential seating is recommended for both of them, but for different reasons. Your student with auditory processing needs preferential seating because they need very little that gets in between you and the teacher, the speaker. So the student needs no distractions when they have attention deficit. So for auditory processing, I want the student as close to the speaker. I want no distance between them and no background noise. For attention deficit, I don't want 4 rows of students in between that's going to distract me. So for two different reasons, they need it. In background noise, we want to reduce it for both. One, for students with attention deficit, it's distracting, meaning their auditory system can likely understand speech and background noise, but the background noise is so distracting that they can't focus. Versus auditory processing, that we need to get rid of the background noise because their auditory system does not understand speech clearly in the presence of background noise. So sometimes working on recommendations that are appropriate for both can help, but there are issues that are separate. For example, with attention deficit, you're going to have inconsistent academics because of lack of retention, where some days they can do it, next day they can't. Children with auditory processing never have a day where everything goes well. They have slow progress academically, but not spikes or up and down yo-yo days. So you're going to see that difference in some of those behaviors as well. When you talk about medication as treatment for attention deficit, I'm always surprised that when I have an evaluation for auditory processing and I don't diagnose it, or I say that auditory processing is not the student's primary driver, meaning it's not the primary problem, that parents are often disappointed. And it's because they want the child's difficulty to be auditory processing instead of attention deficit. And when I get to ask them why, the number one reason is I don't want to medicate my child. And what I tell families is I understand that and respect your decision. It does not mean you can ignore the diagnosis, because attention deficit does not go away and they do not outgrow it. As they get older, they can develop strategies to work through it, but it is going to be there. And the harder things get academically, the more you're going to see the inattention and difficulty show up. So you cannot ignore the diagnosis just because you don't want to medicate your child. There are several other options out there, and medication is only a small part of the treatment for attention deficit. The majority of it is behavior management and teaching the student why their brain is different, finding out where they struggle, and developing procedures and protocols in their day to help accommodate for that. So things like when they do their homework, it goes right into the book bag so they don't forget it. Or when they leave the class and they've written it down in the assignment notebook, the teacher can check it for accuracy to make sure that they have everything correct in their assignment notebook. Things like having the student make visuals to remind early morning routine issues, or when they get to school and they forget to check their mailbox and do their morning routines, they can draw a picture and put it on their desk to help remind them, giving them visual reminder. So a lot of behavior management needs to happen outside of medication. There are also alternate treatments. The American Academy of Pediatrics published a few years ago a study on the benefits of supplements, omega-3 and omega-6, in terms of prefrontal lobe activity and focus. And so I tell parents, try supplements, talk to a nutritionist, look at diet. There's emerging research on diet. And it does say that protein is very important because protein helps neurotransmitters synthesize together. And so the challenge with protein is that it is not convenient when you talk about breakfast in particular, that everything convenient is carbohydrates. So often when I have an evaluation, I have students that show up with, a Mountain Dew and a honey bun or something in plastic that's full of sugar and carbohydrates. And so I explain to parents that really what you need is protein in the morning to help that student with neurotransmitters. The other issue that affects focus outside of even a diagnosis of attention deficit is hydration. And so in brain research, there is evidence that a lot of our students are dehydrated. And so one of the things we want to do is recommend hydration. In order for the brain to focus, it needs to have oxygen. And in order for oxygen to get to the brain, the lungs have to be wet. And so if there's a lack of hydration in a child's body, then you're not going to see that focus. And I'm not talking necessarily about attention deficit, but in general. The other thing that is known to help focus is movement. So movement, either prior to a classroom, in the middle of it, or a therapy session, gets that oxygen flow going to the brain, and it improves focus and retention. There is a lot of research on the requirement of motion and exercise for children with attention deficit, the hyperactive, because if you tell a hyperactive student to sit quietly and don't move and focus, it is neurologically painful. Their brain is giving them a signal that they have to move all the time. So a lot of that behavior management is giving that student an appropriate movement for the classroom that is not disruptive. So in a lot of, say, gifted and talented classes that have a high percentage of attention deficit, you will see, instead of chairs, you might see exercise balls that they sit on. Or a good suggestion is to put a piece of Velcro under their desk and they can just rub it back and forth, which gives them the sensory input of motion, but it's not disruptive. Or a squeeze ball that they can touch. Some other suggestions have been to put exercise bands around the legs of a chair so the student can kick and move the exercise band. It doesn't make a lot of noise. An occupational therapist I work with recommends slicing a tennis ball and putting it on the edge underneath one of the legs of the chair. It gives the chair a half an inch of movement that's not disruptive. So the behavior management can be critical for attention deficit. So some of the characteristics when you look at auditory processing versus attention deficit, when you're looking at auditory processing, their difficulties are going to be modality specific, meaning they may be distracted and inattentive in background noise, but when it's quiet, they're fine. Children with attention deficit are going to be distracted even when it's quiet. So when I teach speech pathologists and teachers about this, I say, if you have a student in a quiet environment, one-on-one, and they're having trouble attending and focusing, it is likely not due to an auditory processing deficit. It could be due to attention. Auditory processing kids are going to have difficulty in background noise because it's not clear. And so the analogy I give is that if someone starts talking in a foreign language and you don't understand what they're talking about, how long are you going to stay focused? Not long. So you're going to see kids that may get fidgety and have decreased focus, but only when there's background noise. So attention deficit is all modalities. If you are working with a child with attention deficit and the cafeteria smell comes in, they're immediately going to be thinking about lunch and you've lost their focus. Smells, lights, visual, auditory, all of it's going to distract them. Where with auditory processing, it's only the auditory modality that's going to be affected. The other thing you will see with attention deficit, especially the hyperactive kids, are impulsive behaviors. And those of you that work with children have all experienced this, where they will do topic switching or they'll interrupt. When you're doing APD testing with the student like that, often as the stimuli is being presented, the student is asking, are we done yet? Or what was that? Or they're trying to tell you a story of something else. So again, it doesn't mean that it's necessarily an abnormal response because they didn't hear it clearly. It's wrong because they were talking. And it's very important as we document our test scores, we mention that. So if 3 out of the 6 errors of a student were because he was talking while the stimulus was being presented, that doesn't necessarily mean it's an auditory processing deficit. It means that they were talking through the test. And it's important to document that because that suggests a different problem than an auditory processing deficit. The other thing that you can see with attention deficit is certain error patterns. So when you're doing a test, say a filtered words, there are certain patterns of errors that are typical, even if someone has normal auditory closure. So for example, on one of the filtered words tests, the stimuli is path, P-A-T-H, and a very common error is have. A student will say have. If this word is path and the student says dog, that's a red flag because it's so different. It's not even close to the stimuli. The other thing you'll see that's well documented in the literature is error patterns of I'm getting 6 correct in a row and then I get 6 incorrect. Then I come back and I get 6 correct. So you see these sort of lines of correct scores versus incorrect. And what that suggests is I'm going to start out the test and stay focused. I get 6 right. Okay, this is boring. Now I've lost focus and I come over here and I get 6 wrong. Oh, I'm not paying attention. I need to come back. So if you have an auditory processing deficit, your errors are going to be more spontaneous and intermittent, not in rows of correct and incorrect. And that goes not only for auditory processing, but any evaluations, whether it's school eval, testing, whatever it might be. So how can we differentially diagnose some of these disorders with auditory processing? One of the ways to do it is to rule out auditory processing, which is the majority of what I do clinically. I will test them and say it's not auditory processing, it's likely language processing or attention deficit. So we need to stop talking about auditory processing and focus on what the primary problem is. And I've given suggestions already on ways to look at behavior, how to evaluate other test scores. For example, on your IQ measures that are done in schools, there is typically a verbal IQ and a performance IQ. Verbal IQ scores are very heavily language loaded, and typically in students with auditory processing, you're going to have a lower verbal IQ and a higher performance IQ because performance IQ tests are very visual. On every IQ test, there's also a subtest of working memory. Working memory is the ability to listen or read hold the information, process it, and respond. And so working memory deficits are very consistent with attention deficit. Also short-term auditory memory. So if you look at a psychoeducational test from the school, and they may have a solidly average verbal and performance IQ, but their working memory is an 80, that suggests attention deficit. The challenge with school-based evaluations is they do not diagnose. So if you have a psychoeducational test done in the school system and working memory is deficit, they're not going to say there's a diagnosis of attention deficit. They're going to say, how can we help accommodate the child's issues in the classroom? A true diagnosis has to come from outside the school in order to make that. But we want to rule out auditory processing, look at language skills. Is that an issue? Know that auditory memory is going to be deficit if there is attention deficit, and make those connections. So there's different ways that you can differentially diagnose. Looking at the test qualitative data or clinical observations for testing, making judgments about the validity of the testing based on their responses, looking at things like the impulsive behaviors. You don't see impulsive topic changing in auditory processing because they're not sure quite what you're talking about. So they're not going to respond inappropriately because they're not going to respond because they're not sure if it's correct. So there are differences in those behaviors that you'll see that can help differentiate it. There's a lot of controversy. We've talked about auditory processing. The reality is evaluation tools for attention deficit are just as controversial. They are done by a checklist of the Vanderbilt or the Connors, where the student or the parent and the teacher fills these out. They take it to the doctor for a 12-minute visit where the child is scared they're going to get a shot, so they're sitting quietly, and the doctor says, I don't see the condition. So there's not a very definitive way. There are computerized tests of attention deficit. The token test is one, but in my area, they're not given very often, because if you have a child with average or above average intelligence, they can figure it out. So it's not the best indicator. There is a test called the Auditory Continuous, I'll have to look that up, performance test, ACPT, that is known and sensitive to attention deficit issues. So if you have a student that you're not sure or you need more data as part of an auditory processing evaluation, you can give the ACPT, and that is highly correlated with attention deficit. But based on all the behaviors I've talked about, I can almost just by behaviors tell a family if attention deficit's worth further evaluating. So some of the other conditions that have literature for this week in the materials are dichotic and temporal difficulties with dyslexic students. In Europe, there's emerging data on auditory processing deficits in children with autism. Previously, it has been said that, and I have seen this when I test, that you can have autism, particularly high-functioning autism like Asperger's, and have intact auditory processing skills. By nature of having autism, those students are not going to be good listeners because it's difficult for them to focus. The research coming out of Europe is saying that there can be some underlying auditory processing deficits. The challenge is, depending on the severity of autism and how much it's affecting their language skills, it's difficult to test the children. And one of the articles I posted this week actually has done electrophysiology testing for these students, which is some promising ways to look at their auditory processing function without behavioral testing and accounting for possibly some of the language issues. There's also several studies looking at temporal or the slow processors, that temporal processing may be deficit in stuttering patients. And so there's a relatively recent article I just posted on the people that have been diagnosed with stuttering that do have some timing deficits from an auditory processing standpoint. The other condition that we talk about a little bit is auditory neuropathy, or dyssynchrony. And that certainly has its own diagnostic criteria of needing an ABR, an OAE, and sometimes reflexes. The difference between auditory dyssynchrony and auditory processing is the pure tone testing. So auditory processing is assuming normal pure tones. They can hear the beeps. When you get into AN or AD, you're going to see fluctuating pure tone responses. And so that's another way that you can look at that. Symptoms, though, are very similar. So you're going to see difficulties in background noise, speech not being as clear in certain situations. But again, you want to follow the diagnostic criteria for that. In terms of academic impact of auditory processing, there are several ways. If you look at subjects, typically with auditory processing, you're going to see language arts, spelling, reading affected more than math, especially in the early grades, because math tends to be visual. But what I often ask is, are they struggling with tests or homework? If it's due to homework and they're not turning it in, and that's why their grades are going down, again, that's attention deficit. So where are they struggling academically? From a communication standpoint, where are they struggling? Are they having trouble following auditory directions? Do they not verbally respond when appropriate? Could there be some word finding difficulties? Are they not participating in class, raising their hand? Are they not socially interacting with their peers? Do you see them having conversations, or are they withdrawing? So what's their social communication abilities? When you ask questions, are they using a wide variety of vocabulary, or giving one-word sentences or one-word answers? So you want to look at where is the communication being affected. In terms of reading, there are several different reading skills. The first reading skill is the ability, is actually phonological awareness, which is the ability for the brain to tell that cat has 3 separate sounds, and that k is the first sound, a is the middle, and t is the end sound, without letters. Phonological awareness occurs without letters. If I can't hear that there are 3 separate sounds and where they occur, then I'm not going to be able to do it when letters come, because in the English language, letters don't play fair. The T says this except for these 12 times. So if I don't hear those differences now, and then you give me letters, I'm going to struggle. And that can lend itself to what's called decoding difficulties, where I have a word that might be even a nonsense word that I cannot sound out. I have trouble learning my letter and sound correlation, and certainly cannot put them in, if you put them in any order, I cannot sound out the words. So you're going to see some decoding or phonic-based difficulties. Sight words are a totally different issue. Sight words we don't sound out. So it's more of a memorization, a symbol imagery skill. So that's going to be a different type of reading problem that's not necessarily affected by auditory processing. And then reading comprehension can be due to several issues. One, it can be a late onset difficulty from an earlier auditory processing deficit because it's affecting their language. But reading comprehension difficulties are typically due to one of 2 things. One, with attention deficit, they have a poor working memory. So as they're reading, they're not picturing what they're reading. They can't hold into memory what happened in the story. So when you go to answer questions about it, that they've lost it. The other issue with reading comprehension has to do with language processing. As I read, I picture what I'm reading. If I have difficulty picturing the detail of what I hear or I read, then I'm not going to be able to answer questions. So 2 different issues. One is if I have working memory deficits, the information doesn't stay. If I have language processing, I don't have a good picture. And so strategies for that, for example, if it's language processing, is as a student, before they read a book, they watch the movie. Because it gives them the picture that they can hold on to as they read, and it helps to fill in those blanks and help them picture what it is that they're reading for that. So typically the children that I see have normal language skills, meaning a typical language assessment in the schools, which is, it's called the SELF or the TOLD. They may have little pockets of that they have low scores in that don't have visual, but the majority of those skills are average. So then why is the student struggling? It's because we're missing either that bottom-up clarity piece or the phonological awareness, which can be memory also and language. And then we also want to look at some of these reading skills and academics and see where the student might be having difficulty. In terms of auditory processing in the school system, if you have a moderate or worse auditory processing disorder, treatment for that has to come from outside the school in addition to school-based. Not because the therapists aren't good, but they don't have the students enough. So 20 minutes once a week in small group is typically what a student will get in school-based speech pathology. And it's difficult to get the level of intensity needed to remediate auditory function in the brain by that. So often we're recommending outside services. That can be individual speech and language therapy, computer-based programming, or home programming where they're going to do activities. In all of the United States, except for these 9 states in the Pacific Northwest, auditory processing does not qualify a student for an individual education plan by itself. So in our state of Indiana, I'm typically referring them back to the speech pathologist and telling them what tests to do that I suspect will show some glitches, get them time with the speech pathologist, and get accommodations in place. In the 9 states in the Pacific Northwest, this requirement is from the Federal Department of Education. Each state can interpret that recommendation differently. So when I teach around the country to different speech pathologists, there's literally states that are trying to determine what is our protocol for auditory processing, evaluation, and treatment. But I'm very open with those therapists and with other stakeholders that if it's a moderate or worse, even if you provide ongoing therapy, the goal in schools is not to remediate the disorder. They just don't have the student enough. So one of the things to consider when you look at doing an auditory processing assessment is the child struggling academically? And the Educational Audiology Listserv recently talked about a student that was an AB student that the school team, he'd been diagnosed with attention deficit, which was being treated, and the school team felt like his biggest academic impact was in organization. For some reason, mom went outside and got an auditory processing evaluation that showed a deficit and came back and said, I want all of these recommendations to be in place at school. The challenge is if the student is doing well in school, meaning they're not failing and they are making progress, some of the recommendations may not be provided. There has to be an educational impact for the disorder to warrant an education plan. And then what supports or what remediation is going to be appropriate for that type of deficit, which we're going to start talking about next week. When you look at recommendations for auditory processing, particularly educational, you're going to look for classroom management, meaning what's the environment look like? You're going to talk about teacher style, maybe some academic changes like a foreign language waiver, and then certainly direct therapy. Who needs to be working with the student? Again, that might be the speech therapist. It could be an audiologist like myself that does a 10-week program. It also could be computer-based programming like Hear Builders or Fast Forward, and communication strategies. So you're going to see various types of recommendations in a report. The diagnostic criteria that was recommended by ASHA and AAA a few years ago was basically that of the 5 skills we evaluate, 2 out of the 5 have to be -2 standard deviations below the norm, which is pretty significant. So a lot of times it depends on where the student's cognitive skills are. If you have a high IQ kiddo, even an average score on auditory processing may be considered a deficit for that student. So you have to look at the whole picture of the student, not just the test scores. The last thing we're going to talk about are different profiles of auditory processing. There are two different camps with this. One of them is the Bellis-Ferre profiles, which are in the textbook for this week, that talk about taking the diagnosis, the related issues, and then helping to quantify recommendations. So if a student falls into these profiles or categories, it can be very helpful in terms of trying to see what needs to be recommended. It's still very skill specific and deficit specific. It's just a better way to organize them. The other one are the CATS or Buffalo models of auditory processing that were initially based on the SSW but have been expanded to include other tests. And so again, similar issue, they take the behaviors, related issues, put them together so that recommendations can be provided. In my experience, about a third of the students fall nicely into these categories and 2/3 do not. So if I can use them for ease, I can do handouts based on that type of deficit to make it simpler. But there are some benefits to using the profiles if that does match. And in this week's information, you have a summary of the Buffalo models, and then the book, Bellis book, outlines the Bellis-Ferre. In the book, which is a little older, they list 5 profiles, and they've eliminated the last 2. So really it's the 3 profiles at the beginning that Bellis and Ferre have, which is integration, decoding, and prosodic.